So I have the big honor now to introduce you to our last speaker of today, Professor Dr. Michael von Wolff. He's a gynecologist and the leader of the Department of Endocrinology and Reproductive Medicine in the University Hospital in Bern. And his main focus in research is fertility, preservation, and cancer. And in this context, he's one of the founders of the network of Fertility. And he will share today with us his expertise on fertility and cancer, which is an important topic, especially for younger patients under system therapy whose family planning is not yet complete. So thank you very much for coming today.
Yeah. Thank you very much for the introduction, and thank you very much for being here. It is a wonderful location, I have to say, with I just see the Swiss flag over there. Couldn't be better. Yes, that's the topic, fertility and cancer, and I was asked to talk about this. And just to let you know, it's a huge area. It's a huge area. We just published the 3rd edition of our book. It's a practical guide, 580 pages, big, so it's difficult to summarize in 30 minutes. But I was thinking which areas might be of major interest, and that's what I did. So I summarized the whole topic and will focus on these topics. So I will give you some background information which is relevant for you, and then of course a major topic for us is fertility preservation. I will talk about that, what can be done to protect fertility, what are the major techniques, measures which can be done. I will tell you what can be done to indicate these procedures, and I will tell you what should be done after chemo or gonadotoxic therapy. Let's start with background information. Well, it was just already mentioned that this network Fertility exists. It's just a network. It had been founded 20 years ago. But when you talk about this and when you work with this, then you come across with this network. It's a big thing. 168 centers which are partially specialized on fertility preservation because it's a complex issue, and that's why we had founded this. While Switzerland is the German part, it's mainly Germany. And I also talked about this book. And I want to show you the book because you can get it free. And it's important if you are interested in that. The German book, it's on the left page. It just came out again, and it can be downloaded free of charge when you go on the website. But you have to wait till April, then it will be uploaded and everybody can look at it. It's paid by, well, it's prepared by us, but it's paid by Ferring. And it's 2,000 print editions are printed now. And if you want to get it in English, then you have to wait till summer. Then you get it from Springer. Okay, what is a gonadotoxic therapy doing? Well, there are males and females. I will focus on females because females are much more complex than males. That's what here you can see the ovarian reserve, which goes down up to the level about 1,000 oocytes are left, and then women enter menopause with 1,000 oocytes left. And that's what's usually happening. But when the women get a chemotherapy or radiotherapy, then the ovarian reserve goes down. Depending on the chemotherapy, it goes far down. They might enter menopause straight away, but in most cases, it is not that much affecting the ovarian reserve. It goes down, let's say, up to this level, and then it goes further down, and we have no idea whether it's kind of going down the same speed as in nature or a bit slower. We just don't know. But this is happening when we get a chemotherapy, when women get a chemotherapy, and that's the reason why we have to take care of their fertility. And as you can imagine, it's very much dependent on different factors. It's dependent on the strength of the chemotherapy, the dosage of the chemotherapy, and the ingredients of the chemotherapy. And we know that alkylants are the worst one because they cause DNA breaks. So alkylants like cyclophosphamide, ifosfamide, these are the worst ones. But there are others like MTX, methotrexate, or also cisplatin, carboplatin, which are not that aggressive. So it's very much depending on what the women get and what they get and what kind of combination or what dosage they get. And it's very much dependent on the age of the women. If they get a chemotherapy and they already have a low ovarian reserve, it's more relevant as if they are younger, like in children. This topic or this slide might be very relevant for you because when the immunotherapeutics were introduced several years ago, we had no idea if they might also affect fertility, and many studies are going on, many studies in mice are going on, and I just summarized it and just made this single statement, and I can tell you, according to the literature so far, immunotherapeutics do not seem to affect the ovarian reserve in a clinically relevant. It might affect the function of the pituitary gland, for example, for checkpoint inhibitors, but that's not a big issue because we can give FSH if this happens, but the gonadotoxicity, there's a risk of gonadotoxicity is very low. So these are very good news because quite a lot of chemotherapies or some ingredients, highly toxic ingredients, are now replaced by these medications. So the problem or the risk of becoming infertile might decrease in the future. What else is very important, I made these two statements, is if a woman had a chemotherapy many years ago, then there's no risk at all. There's no known risk for the babies which are born later on. So many oocytes will be degraded, many oocytes will become apoptotic and will go away, but those who are still there will be okay, will be function normally, and the children has no increased risks to get a malformation or whatsoever. Only if the women got radiotherapy, and I'm talking about pelvic radiotherapy of the ovaries, of the uterus, then there might be some risks, because if the uterus is irradiated, then there's a risk of getting smaller children and premature deliveries. But this is only in very few cases. So the first sentence is a very important one. And yes, these are good news. So, as I said, we want to protect the fertility in these patients, and there are different measures which can be performed to protect the fertility before cancer therapy, after cancer therapy, and I will tell you what kind of options are available. The first question is, what kind of patients are we dealing with? These are different charts. This is for those women who did ovarian stimulation, those one who froze ovarian tissue, but I just want to show you, these are breast cancer patients. So these patients had been seen by Fertility Protect centers, breast cancer patients, Hodgkin lymphoma. So most of the women we're dealing with are breast cancer women and Hodgkin lymphoma patients. And the last 25-30% are patients with sarcoma, gastrointestinal tumors, brain tumors, whatsoever. But the main patients we are dealing with is breast cancer, and the younger ones, Hodgkin lymphoma patient. It's probably the same for you. These are the main diseases which are relevant. If we think of freezing something, if you think of protecting the women's fertility, then we have to indicate them to do that. And to indicate that means we have to follow this kind of flowchart, and all these 5 criteria needs to be fulfilled. If they are fulfilled, then we can go for fertility preservation. If they are not fulfilled, we should not go for fertility preservation. And I will go through these slides, these different criteria in the following slides. The major one, of course, is this one, which means the risk of infertility needs to be high enough. What is high? What does it mean, high enough? Very difficult question. Well, the Ministry of Health in Switzerland said or defined that reimbursement is possible if the risk of getting azoospermia or amenorrhea, I think they probably mean infertility, but that's what they're saying, azoospermia or amenorrhea, is at least 20%. And if the risk is that high, then yes, there will be reimbursement. So I think this number is quite okay and is quite usable. So if the risk is 20% and more, I think we should go for fertility preservation. Or, of course, if the patient says the risk is lower, but it's very important for her, then you can do it at a lower risk, but then she might pay for herself. So if all these criteria are fulfilled, we go for it. Otherwise, we should not go for it. The problem is with this 20% risk, what does it mean? As I said, the Ministry of Health says azoospermia or amenorrhea. But infertility is much more than just amenorrhea. And what I did, I just show you the flowchart with all in this book. We created flowcharts for all different diseases, and that's the flowchart for the indication of fertility preservation in breast cancer. And this box tells you when fertility preservation should be done. And this box includes that it should be done if the woman will be between 35 and 40 years at the time when she's going to when she wants to have a child. This is a very relevant issue. For example, in breast cancer women, receptor positive, they will get an endocrine therapy for 3, 4, 5 years or even longer, and she will need to wait for that long. So even if she will have her period just after chemotherapy, we should look at the time when she will expect, when she wants to get a child, and not just the moment after the chemotherapy. Something else, endometriosis is not cancer, but endometriosis, which is not reimbursed, by the way. But here is the same. Here is a box which tells us when fertility preservation should be done, and it should be done if a woman have endometrioma in both ovaries. So other factors, under infertility factors, also needs to be considered to indicate fertility preservation. And so it is quite complex. It's more than just what the Ministry of Health says, risk of amenorrhea 20%. It's far more complex, and we should consider all this. So it is always also a kind of individual decision to go for these measures. Is there an upper limit? An upper limit, because I said the women should be less than 40 years of age. Well, that's because the Ministry of Health says upper limit, age limit is 39. But there's also an upper age limit, because if the woman is too old, then the chance to get pregnant with a material which has been frozen is too low. So there is no real chance to get pregnant. That's why there's an upper limit. And regarding ovarian tissue, it's probably 35 years of age. So if the woman frees ovarian tissue at a young age, the chance to get a birth is 40%, but if she is 40 years old, the chance is about 20%. So internationally, we are somehow defining 35 years as an upper limit regarding freezing of ovarian tissue. If it comes to oocytes, we have a bit higher age limit, but also in oocytes, I show you these curves to give an idea. The blue curve tells you what the chance is to get a baby when you freeze oocytes in relation to the number of frozen oocytes. And if the woman is, let's say, 38, 39 years old, then you might freeze 10 oocytes, and the woman has a chance to deliver a baby using these oocytes of 40%. If she's 41, she will not get 10 oocytes anymore. She might get 5 oocytes at a much lower quality. It's here 5, and then she will have a chance of 10%. You see, 10% is not really that high, and that's the reason why we usually define the age of 40 as an upper limit. Is there a lower limit, meaning that women should have a certain age to freeze something, to undergo fertility preservation? Of course, there is never a real strict lower age limit, but what I want to show you is this study, what they did is they analyzed the rate of the percentage of women, 100% here, 70% here, of women who got a chemotherapy with alkylants in their childhood or in their adolescence, and they demonstrated how many women still have a regular period, and almost all women still had a regular period up to the age of 30. So I think in children, in adolescents, we should be very careful that we don't do too much, because if we take an ovary out in a 15 years old woman, we do a lot of harm. And I personally think we do possibly more harm than good, because these women can still freeze oocytes at the age of 20. So I'm trying to push people to be very careful with the indication, only to do these methods if it's really necessary. And I think in children, in adolescents, it's a bit controversial, and we shouldn't do too much, which is different in other countries. In France, they're freezing everything, yes? So it is very different which country you're working in. In Israel, we just had a speaker from Israel, they're doing a lot, yes? So it's very, in the UK, they're very restrictive. So it is very different in the European countries. What I also said is the survival rate of the women should be high enough, but that's difficult. I mean, you know, when you see a patient and you send a patient to us, we're sitting there in front of the patient, they just got a diagnosis, they didn't even have a CT scan, and we have to estimate what is the survival rate. It is difficult, to be honest, but that's why we have these big books, because we have 15 diseases, and we describe everything for the 15 diseases, but we have to define which woman has a sufficient survival rate. There might be solutions like the TNM classification, so stage 4. In stage 4, we shouldn't do anything. But when you look at these breast cancer women and these Hodgkin lymphoma women, stage 4 means 5-year survival rate 20%, lymphoma 80%. So this is also not a solution. So we really have to take all the data for each disease to see what the survival rate is based on the limited information we have at the moment when these women are counseled. But it is possible. But I just tell you, we need the support from the oncologist usually to get a good indication not to do too much. What we had done so far is we wanted to know, or I think that's one of the most important things, to know what is the risk for certain diseases, certain chemotherapies to become infertile. And just to give an idea, I think that's the most important thing we have to do now. I mean, we are being busy for 20, 30 years. The first 5 years, we were very busy to develop the techniques, and we were very busy to set up that so many centers have established the techniques that everybody can take advantage from it. Then we managed to get the reimbursement, and now we have to clarify the indications. So what we do, we have a big project, and we establish, or we analyze the whole world literature for 10 different diseases, as you can see, from the bone cancers down to leukemia, and analyze what is the published risk of infertility. And these are all meta-analyses. So it was worthwhile doing it, but still not that helpful. And you see here the confidence intervals of these meta-analyses, and you get ranges of 14 to 44%. And you know, chemotherapies are so different, like in Hodgkin lymphoma. So it is helpful, but it's not that helpful anymore because treatments are changing. So there is quite a lot still to do, but I'll show you in a minute. What I also told you is that we should do these procedures without risking the health of the woman. That's also something, especially in breast cancer. And there was a huge discussion when we started with that. Is it possible to postpone the chemotherapy for 1 week, for example, in a neoadjuvant chemotherapy in breast cancer? And the oncologist says, "Ooh, no, impossible." Well, but nowadays we know it is possible. I just want to show you this diagram. It tells you what is the overall survival rate, 100%, 0% over 15 years in women, in which it took 30 days, blue, 30 days from the diagnosis to the start of the therapy, 60 days in green, more than 60 days in red. So if the delay is limited, then the risk for the woman is not there. And the very first observational studies confirm that there is usually always a week or even 2 weeks to postpone the chemotherapy to undergo fertility preservation measures if the woman wants to do it. There's only, of course, some diseases that might be different, but overall there is enough time. So what techniques are available? These are the main techniques: GnRH agonists, oocyte freezing, or tissue freezing. And I will very briefly go through these different techniques and tell you what the state of the art is. Well, GnRH agonist had been introduced 20 years ago. At the beginning, all oncologists says the worst, because said, "Don't do this, so dangerous, it will kill the women," but it didn't kill the women, it didn't do any harm, it even helped the women. So it tells us how attitudes can change. And now we have these meta-analyses. So these are all RCTs, randomized controlled studies, mainly from breast cancer women. And this meta-analysis tells us that the chance to resume menstruation after chemotherapy is 3 times higher if the women get GnRH agonist in addition to the chemotherapy. But of course, these are studies, so these studies defined a short-term outcome, so it was a follow-up of 1 to 2 years, and it has been mainly analyzed in breast cancer. So in breast cancer, it seems to work regarding short-term outcomes, meaning it decreases and increases the chance to resume menstruation for the first 1 to 2 years after the chemotherapy. That's what the studies tell us so far. However, we get a higher chance to resume menstruation, but so far we have not been proven that we also get a higher chance to get a baby. There's a difference. So we protect the menstruation, but we not protect the fertility. That's what it means. Well, I mean, it's borderline significance, but menstruation and fertility is a bit different issue, so this has still to be proven. And, as I said, it was a short-term outcome. And this is the only study for breast cancer, long-term outcome, 7 years. And this is the chance, the resumption of menstruation, and the curves with GnRH agonists, blue, and the one without. The curves are very close, so the effect seems not to be that long. And in Hodgkin lymphoma, these curves, which is FSH concentration, even cross here after 4, 5, 6 years. So there is no long-term effect at all. So GnRH agonists are super, and they even control heavy menstrual bleeding in these women, and they work for short term, like in breast cancer women who wants to get pregnant because they're older, usually just after chemotherapy, but they're not a treatment which solves the problem for younger patients, like those ones in Hodgkin lymphoma. And that's the reason why we also should think about ovarian stimulation and oocyte freezing. And I don't have many slides for that because it's a kind of standard in vitro fertilization therapy, meaning normal hormonal stimulation for 20 days. And nowadays, we can start whenever we want. So it's called random start stimulation. We don't have to wait for the period. We can start on day 7, day 14, day 21 of the cycle. It doesn't matter. We need 2 weeks. Finished, we freeze, we get the oocyte out transvaginally, and the chemotherapy can start the following day. So this is simple, and almost all infertility center offers this because that's anyway something they do every day. So it works quite well. The other technology which is very fascinating, it's not that common anymore in Switzerland, but still quite common in Germany. But I think we have to think about whether we should push it a bit more, is ovarian tissue freezing. And what we do is we do a laparoscopy. We take a whole ovary out like here, or we take 50% of an ovary out like here. It's very simple. It doesn't look very nice, but it's a very simple operation, 50% of an ovary out. We freeze it, and we freeze it in specialized centers, so the tissue is transported to specialized centers, for example, 2 hours, or one in Düsseldorf, there is one in Bonn. The tissue can be transported at 2 to 4 degrees overnight, which works, and we're just publishing that it does work. There is no reduction of the life expectancy if the tissue is transported overnight at 4 degrees, which is amazing, isn't it? But the ovarian tissue is extremely robust. So you can keep it at 4 degrees overnight, and then it's frozen in specialized centers, and then it's retransplanted. Retransplanted means we do a laparoscopy, and then we identify the ovarian fossa. This is where the ovary usually is situated here, and here we can see the fimbria, and here's the ureter, and we make a small incision, and we put the small pieces into this pocket, and you can see here the pieces, and then you close the small incision, and then it takes about 3 months, and hopefully the woman get underneath the peritoneum a kind of ectopic, heterotopic ovary, and it works quite well. And these women can get pregnant spontaneously. 50% get pregnant spontaneously. Others need aspirations of the oocyte. It's amazing it works. It really works. It is so amazing, yes, that it does work because it's so simple, but it works. And the question is, which technique is better than the other? This slide is totally new because we had in Fertility Protect the largest cohort now of ovarian tissue transplantation of 401. And what I just did is I took the papers in which people now publish this overall success rate, meaning live birth rate after freezing of oocyte before cancer. Let's take these ones, not age groups, all ages. Ovarian tissue, we had 30% live birth rate after transplantations per woman. Oocyte, we have 30 to 32, 35%. So even though we thought at the beginning oocytes we thought oocytes are better than tissue. Now we have to say we're just going to analyze this statistically, but there's probably no difference. So both techniques are probably equal regarding success rates and have advantages and disadvantages. However, for ovarian tissue, of course, there are also some limitations. We have to be very careful with regarding certain diseases in which we have a risk of having cancer cells in the ovaries, like in leukemia, lymphoma, neuroblastoma. So there are certain limitations, and these patients, we shouldn't freeze oocyte or ovarian tissue, but anyway, we can't do freezing of oocyte because we don't have the time. So for each of the technologies, we have certain indication risks and advantages. What is the reimbursement policy in Switzerland? I already told you there are certain limitations, and I just created this one slide to tell you. Well, the technologies are reimbursed, and the tariff is quite good one. We can be happy. We can be very happy in Switzerland because in Germany there's also reimbursement. But in Germany, Germany is a bit special. I'm German, so I can say that. Germany is a bit special, so the tariff is so low that the centers don't want to freeze anymore. And a patient in Berlin who wants to freeze her oocytes, she doesn't find an infertility center because the centers don't want to do it because the tariff is too low. Switzerland is high. We are happy. But it's not reimbursed in all cases. It's reimbursed in malignant diseases. In benign diseases, if they get alkylants, for example, if they have a lupus disease, only beginning in women post-puberty, starting at the age of 13, 14, up to the age of 39, if the risk of amenorrhea and azoospermia is more than 20%. These are the criteria for reimbursement. And what is reimbursed? Stimulation of freezing of oocytes, removal of ovarian tissue and freezing, transplantation of tissue, freezing of sperm and testicular tissue. So we can be quite happy to be in Switzerland that this is reimbursed before chemotherapy. What I told you is that we still need strict indication in which cases tissue or oocytes should be frozen. And as I told you, we have set up this huge project here, Fertility in Germany, Austria, Switzerland. We are collecting data, AMH concentration before and after chemotherapy. It's a prospective analysis with 50 centers because we really need these data. So far, only 5% of the frozen oocytes, 5% of the tissue, 5% of the frozen sperms are recalled by the patients. So 95%, it's still frozen, possibly will never be taken by the patient. So this needs to be improved. So we need strict indication. That's why we're having this huge project, which is now extended to Europe. And we got a huge amount. So other European countries, including Switzerland, are also contributing to it. And this project is so important. It's almost this last slide. I just want to show you those who maybe know something about Hodgkin lymphoma. I mean, we had ABVD and we had BR-CoP escalated. So these are the main treatments we had. And here we started the project. These are the first patients coming back now after chemotherapy. And BR-CoP is gone because this breakcut has replaced BR-CoP due to 2 Lancet papers. So it's totally gone. So it is such a change in therapies, Hodgkin lymphoma, breast cancer, and we need to get information, we need to get data of the new therapies. And that's what we're currently doing. Well, I just switched this slide, and I just want to tell you what else we should do, and that's what you can help us. I mean, that's a concept which we had published. We think what we have to do, we kind of second stop treatment. That's what we call it. So women have to be seen before the chemotherapy. We have to evaluate the ovarian reserve. We have to consider primary infertility, fertility preservation. And after 1 year after the chemotherapy, we have to see them again. And we have to evaluate, especially in children, adolescents, what the ovarian reserve is. And if they're very low, we have to take care of their menopause. If they are low, we can still freeze oocyte. And if they are high, we are happy and we can send them home. So we shouldn't just stop the whole thing with this. We should continue to see these patients after cancer therapy. And that's the final slide, the summary. So fertility is affected by chemotherapies, especially in older women, but probably not by immunotherapies. Fertility preservation, such as freezing of oocytes and freezing of ovarian tissue, is a preventive measure in cases with risk of In fertility, patients should be followed up, what I just said, after cancer therapy to possibly freeze oocytes if ovarian reserve is very low. And spontaneous pregnancy after cancer therapy is possible without relevant risk once patients are cured. Thank you very much.
For this excellent lecture. Are there any questions? No? Everyone's tired? Wants to have a break? Are there any questions from the...
There's one.
Yes.
On the first slide, on another for the slides, is there a correlation with? Did you look with the COVID vaccination? What influence it has?
Well, yes, because I was asked by the Swiss medic regarding this topic, but it had nothing to do with cancer, and then because there was a big discussion coming up if COVID has an impact on gonadal function, and as far as all the literature showed us, no.